I think the cool thing in Santa Monica at Providence St. John's Health Center, we offer all these options.
Right.
Everything from A to Z that's available.
That's true.
For men's health, whether it be non-cancerous, cancerous, voiding dysfunction, we have it all. So what are the three most common complaints or problems that men come to see you for?
Three most common would center around prostate health, whether it's benign disease or prostate cancer screening or prostate cancer, sexual health, and that falls under both ED, so erectile issues, and also hormonal optimization. So just dealing with the prostate and erections and kind of overall hormonal health would be the top three.
So if a guy, when you say prostate health, what's the most common thing? Is it urination issues? Is it PSA? Is it?
I think it's probably half and half, but urination issues, affects everybody starting at around age, 40, 50 to a certain degree.
Right.
So
I have to be in that age category. So
are you?
I know.
I would have never guessed. No, so they come and see me because, generally, first of all, guys hate going to the doctor. It's usually either, their wives or their partners or someone that is bothered by them getting up at night or, not being able to get out of the bathroom or taking too many trips to the bathroom during a movie that, makes them come in. But when the guys do come in, a lot of it has to do around urinary health and, how many times that they have to go to the bathroom, how difficult it is to pee. And most of that is centered around an enlarged prostate, right? And that's the underlying cause. And so what I try to do is come up with a plan, whether it's, medical therapy, lifestyle changes, or it's sometimes surgical intervention. Take out the mystery, take out the, what they're afraid of, their virility, their sexual performance, and so on. And so that's what we do.
So the first step, if you're treating urinary problems and you think it's from the prostate blocking the bladder and slowing the stream and they can't empty the bladder well, first step is usually medications?
First step is asking them, about their lifestyle, right? So a lot of guys that are having a hard time urinating sometimes don't, even if they're young, they just don't drink enough fluids, right? So that's a problem. Or alternatively, if they're going, I have 20, 30-year-old guys that come into my office and they say they're going to the bathroom every 15, 20 minutes. And I ask them, and I ask them about, what's their daily routine. And they're like, they usually start off the day with a Red Bull, then they have another, espresso, then they're drinking, 2 liters of water during their gym routine. And so, there's nothing wrong with them.
Fluids
but it's
and
fluid and caffeine, right? And that can definitely do it.
Sure.
But for guys that are older, that they are at risk for having an enlarged prostate, and it usually starts, like I said, starting at age 40, more symptoms at age 50, and every decade moving forward. The first treatment after lifestyle changes is medical therapy. So using something like an alpha blocker like Flomax or Uroxetrol or Rapaflo, any of these medications, and most guys have heard of Flomax, is step one. And then if that doesn't work, then I usually recommend sizing their prostate with an ultrasound and then also looking at their bladder. Because a lot of times their bladder symptoms, so things like urinary urgency, frequency, even getting up at night, are a reaction to the obstruction. So the obstruction kind of takes place and then that causes the bladder to react in a way of either getting thicker or the nerves becoming more aggravated so that they have all these irritative symptoms. So you're doing a cystoscopy, which is just a camera into the bladder to take a look at the bladder health, is really important, especially when you're thinking about surgical management at that point.
What about PSA? How do you know that their voiding problems are not from prostate cancer, which is the most common cancer in men? Right.
So usually prostate cancer doesn't have any symptoms, which is kind of the one of the things that a lot of guys think, oh my gosh, if I'm going to the bathroom all the time or I'm having a hard time, that means I have cancer. But if a guy is over the age of 40, especially over the age of 50, they definitely need to be screened for prostate cancer. Right. If a guy has prostate cancer and also has irritative symptoms or voiding symptoms, then their recommendation would be very different than a guy that has no voiding symptoms and prostate cancer. Right. So we want to make sure that that's ruled out. And part of the workup for prostate enlargement is also PSA screening.
So let's say that you've, a gentleman comes to see you, he's got voiding problems, you determine it's the enlarged prostate, they try medications, those work initially, but then they kind of peter out or stop working.
Yep.
and you want to do a surgical intervention. I know that we have some new technologies that are available, and tell me about those.
Sure. So there's a lot of different options available depending on the size and the anatomy of the prostate. I think the smaller prostates can benefit from things like Resume, which is using steam to help open up the prostate, or the Urolift, which uses these polyester clips that can help open up. So I kind of prefer to open up the curtain. What's the most exciting, and we have it at St. John's now since for the last few months, is Aquablation, which is using water jet therapy to help open up the prostate channel. And what's cool about the water jets is that it's a robotic machine, so it's much more precise than what we used to do, which is the TURP, which is just going in and kind of removing the prostate tissue that's causing the obstruction. The procedures are done within minutes and open up the channel. And patients have done excellent. They do really well, and we can preserve their both ejaculatory function, their continence, and obviously because there's no heat energy, you don't have to worry about potential for damage of the nerves that run outside the prostate that are controlling sexual function.
Okay.
So patients are doing really well. They're very happy. Most of them, by the time they get to that point, they they regret not having it done earlier.
Right. Yeah. Right. Because they urinate much better, they feel better, they're sleeping better.
Exactly.
All those things.
Yeah. Almost immediately.
So the elevated PSA.
Yeah.
Do all those, used to be we would biopsy all those men, but we don't do that anymore. We're much more sophisticated on how we evaluate that. So tell me about that.
So if a guy is, generally between the ages of 40 if they have risk factors, or if they're African American, or 50 if they don't have any risk factors, and between the ages of 50 and 75, and they have a greater than 10-year life expectancy, then they're a candidate for PSA screening. And so PSA screening can usually begins with a primary care doctor's office, where it's just a simple blood test. Depending on what their baseline is, if it goes up significantly by 1 or more points per year, or if their total PSA is above 4, and they're under 70, then they require further workup. Now we have better molecular tests that can screen patients that are both PSA based and non-PSA based.
There's a urine test, a couple of those. There's a blood test.
Exactly.
To help, I think, as I say, it kind of help refine PSA or help us stratify which guys, fall into a category that might need further evaluation, like a biopsy or maybe some imaging, like an MRI.
MRI, exactly. Yeah. So that's generally, if a guy comes to me for an elevated PSA, then I'd start with one of those. The 4K test is the one that I use most often. And I also generally recommend an MRI too, because I think an MRI can help both in terms of determining how much prostate growth or how benign disease there may be, but also identify if there are any areas that are suspicious for prostate cancer, and then also allow us to target those areas. We can treat just the areas that have the cancer, and that's where the MRI and and fusion technology come into play.
Yeah, so I think it's certainly become the standard on the West Coast, and certainly where you and I practice, to do the MRI before the biopsy.
That's right. Yeah, I mean that really is the new standard of care. So then you asked me about what other things guys come in for. So I think ED is huge.
I guess that's well understood by it's erectile dysfunction.
Right.
Can't get it up anymore.
Exactly. Yeah. So the first thing that I do is I look at their cardiovascular health and cardiovascular history and smoking history and diabetes, because basically those are the most important determinants of why someone gets erectile dysfunction. We always look at ED as more of a cardiovascular disease than a urologic disease, because guys that have ED, it's like a 10-year window into potential for having a heart attack 10 years later.
Right, like diet and exercise, smoking, all those risk factors for heart disease also cause ED. I think that's that I think goes to the heart of the matter. Men are concerned about erections, right? And if they're not going to be able to get an erection, that's why they shouldn't smoke.
Yep.
Right. That's why they should exercise.
Right.
That's why they should watch their waistline.
That's right.
Right. Right. So what is heart healthy is
exact prostate health and penis health and all of the above. Yeah, it's actually
exactly
very true. Yeah, and we always say a guy's heart lives in his penis, so it's kind of true. But yeah, so keeping in line with that, it's important, and we're lucky. At St. John's we have great primary care doctors, that generally are checking cholesterol for guys and doing carotid scans and calcium scans for coronary disease.
Right.
But yeah, I mean, a lot of guys that don't have primary care doctors or are just kind of not in tune with their health, they're the ones that are at highest risk, not just for ED, but for cardiovascular disease. You know, I like to treat it from multiple angles all at the same time. And it's really important not to neglect hormonal health, because every guy starting at age 30 loses about 1% of their testosterone annually. So every decade, is about 10% loss. And if you start at a super high number, then even by the time you're 70, you may not have any symptoms and you may not have any abnormal levels. But I see a lot of guys in their 30s and 40s that are starting in the 300s or 400s, which is, for a guy in that age group, it's pretty low, right? There's a lot of options for increasing a guy's testosterone that don't necessarily mean replacing testosterone by injections or creams or whatnot.
You know, I think there are some misconceptions about testosterone. It is true you can get too much of it. So I think if men are going to take supplemental testosterone, it's clear that they need to be under a doctor's supervision.
Right.
And if guys have low T, and certainly if they're symptomatic, but testosterone's important for brain health, for mentation, for muscle health,
bone health,
cardiovascular health.
Right.
Because there used to be, I think there were some studies historically that indicated that giving testosterone or supplemental testosterone may be bad for the heart in some way. But I think that's mainly been...
Those have been refuted pretty much.
Exactly right.
In fact, the American Heart Association supports it for guys that are symptomatic and have low T. So, yeah. But one of the big misconceptions was that testosterone leads to prostate cancer.
Yes.
Right, and I'm sure you come across that being a prostate cancer expert.
Yeah.
But obviously we check their PSA and we do PSA screenings regularly. But I always explain it to them as it's a stress test for the prostate, right? So if someone has undiagnosed prostate cancer and you give them testosterone and their PSA, jumps up, then that's actually, a good way to find out early on that that patient has prostate cancer and treat it and get it taken care of, versus waiting for it to present itself, and it may be sometimes too late. So what are the newer kind of technologies, or what is it that you do in your practice that's different that can help guys regain their continence and their erectile qualities and whatnot after prostate cancer therapy?
Most guys get to the doctor because their wife tells them to, their partner tells them to,
Yep.
Makes them go in, or they've got problems. So it's important to see your primary care physician annually and get screened.
Yeah.
If the PSA is elevated, it doesn't mean you've got prostate cancer.
Right.
Needs further evaluation. So we're more sophisticated in who needs a biopsy, and we can do it while men are asleep. We can do it while they're awake. So it's easier on men, and it's a really very low-risk procedure. Number two, if guys end up having prostate cancer, we're much more sophisticated and intelligent about knowing who needs treatment and who doesn't. That's number one. And probably 40% of men, or maybe 40 to 50% that have prostate cancer actually can be simply carefully monitored. They don't need aggressive treatment. We don't ignore it. We don't forget about it. We just monitor them. Some of those men, maybe half, will eventually go on to need treatment, but they can still avoid aggressive treatment if they don't actually need it when we first diagnose it.
And this is so active surveillance is what you're
referred to as active surveillance.
Okay.
Then, if the cancer happens to be only in one spot or one part of the prostate, we can ablate that cancer, either with heat, with high-intensity focused ultrasound, HIFU, that you're an expert in. Choose to freeze that part of the prostate if it's in a certain part of the prostate, or if it's maybe more aggressive. So we can leave the prostate intact, but avoid radical therapy. If we need to treat the whole prostate, there are great options for doing that. Now, radiation can be used. Sometimes that's used with hormone therapy. But for those men that want to avoid surgery, it's a great option. 60% of men would just prefer to have the prostate out, have the cancer gone from their body. Whereas other men want to do anything they can to avoid surgery. The good news is that we have two great options. Radiation can work well with minimal side effects long-term and still have a great cure rate. With robotic surgery, which has now been around for over 20 years,
wow,
offers really the best possible surgical management. It's much more consistent. We know the anatomy better, we see it better. It's a much more precise surgery.
I tell them Mediterranean diet, 35 minutes of exercise, of high intensity exercise 3 times a week. So the takeaway is there's a lot of options.
Yes.
there's no need to fear the treatment,
Right.
and everyone should get screened.